Thing I want to mention about is prevention of deep vein thrombosis is very important for obese patients. This is modified Capri-Ani risk assessment. This is not much practice in any hospital in our country, but this is a very good predictor of risk of deep vein thrombosis. If the point is more than 5, the risk is about 6. It is a very say 3 is age 75 years, history of deep vein thrombosis, family history of vein thrombosis, elevated serum homocysteine. 2 points, the age is 60, laparoscopic arthroscopic surgery, major open surgery more than 45 minutes, laparoscopic surgery more than 45 minutes, malignancy, and confined to bed more than 72 hours, immobilization of plaster cast. We lost a BHP businessman few months before, like that. So DVT prevention measures, we have to assess the bleeding risk. If it is low bleeding risk, then we can go for you can assess venous embolic risk. Then patient is full ambulatory, no drug or is necessary. If it's low risk, moderate risk, there may be low molecular weight heparin can be given. In high risk, also low molecular weight heparin given. Timing intermittent positive pressure compression is just before surgery, low molecular weight heparin 2 to 12 hours before surgery if high risk. Other thing that we dare not to happen with obesity patient is the pulmonary complications. The common thing is atelectasis, chest X-ray, or even CT scan. There may be pneumonia, ARDS, or there may be some aspiration also, history of or imaging. There may be exacerbation of chronic lung disease and bronchoconstriction. These patients have tendency to bronchospasm. Risk factors are upper abdominal surgery, open thoracic surgery, aortic surgery, neurosurgical abdominal aortic surgery, emergency surgery, age 65 years, OT more than 3 hours, ASA 2, heart failure, albumin less than 3 gram, COPD, smoking not stopped in 8 weeks ahead. So GA has more common pulmonary complications than spinal epidural or block. PSA2 more than 45 is a risk. Abnormal chest X-ray, current upper respiratory infection, and NG tube, post-op NG tube is a risk factor. This is again another risk index that shows if the point is 45, there is 42% or 40% risk of pulmonary complications, and if it is 25, then the risk is only 15%. So as I was telling, you have to stop smoking 8 weeks before. So the least is at least to eliminate carbon monoxide, it has to be at least 48 hours. For asthma and COPD patient, long-acting bronchodilators or inhalational corticosteroids or oral corticosteroid or antibiotics, and if there are flare-up like that, there should be a oral care by the dental visit and pre-op mouthwash daily for 2 times so that the oral hygiene is improved. Some aerobic breathing and exercises in inceptive spirometry and chest physiotherapy to be done. Again, in post-op deep breathing exercise in spirometry, it's better if there is epidural in place with opioids, low dose opioids. For asthma patient or aspirin-induced reactive airway disease, no ketorolac or brufen should be given to avoid nasogastric tube unless needed. CPAP, some patient may need to give CPAP with 10 centimeter of water nasal or facial mask for 4 to 6 hours, especially at night time, may be helpful. This will reduce nighttime incidence of hypoxia, need for intubation and ICU admission and pneumonia.